Hello, everyone. Thank you for attending today's webinar, 13 RPM CCM mistakes we made and you can avoid, presented by Blue Star TeleHealth. I'm Rebecca Kushmiter, and I'll be moderating the webinar. I'd like to start off by introducing today's speakers. We'll be joined by Robert Ray, CEO of Blue Star TeleHealth, and Dr. Michael Rowley, Chief Medical Officer at Blue Star TeleHealth. You can read their full bios on the left side of your window by selecting the Speakers tab. Just a few housekeeping notes before we begin. To access additional resources for today's presentation, please click the Handouts tab button on the left side of your screen. You can access closed captions from the bottom right corner of the video player. The webinar is being recorded. It will be available to watch on demand within 24 hours. During the presentation, you can submit any questions you have using the Questions and Answers tab on the left side of your screen. Time permitting, we'll conclude with a Q&A session. All right, now let's begin. Gentlemen, please go ahead.
Hello, folks. My name is Rob Ray. I'm from Blue Star TeleHealth, and I'm joined with Dr. Michael Rowley, and we are going to tell you about some things that we have screwed up, and we willingly participated with our clients and observed them screwing up. And the goal is to help you all be smarter out there in webinar land. First, 60 seconds of background about us. I'm joined today, we're very privileged to have Dr. Michael Rowley as our Chief Medical Officer. Michael is a West Point graduate, trained in neurosurgery at NYU, a couple of combat tours in Iraq, and then he ran the Army's PTSD telehealth program out of Walter Reed. So we're delighted to have him on board. He's in Nashville today. And then my name is Rob Ray. I'm a Naval Academy nuclear engineer, happened to be a Navy admiral for a while, and I'm the CEO of the company. The company, just so that you know that we're not a couple of guys that fell off a turnip truck and happened to fall into this webinar episode, we've been around since 2015. We've helped families in 20,000 homes. We're based in Washington, D.C., about 40 people. We're a service-disabled, veteran-owned small business. We've won a lot of awards from the SBA, from the governor, from the Better Business Bureau, and we currently provide RPM, CCM, and other services like that to physicians' offices, FQHCs, hospitals, payers, and most recently to the Veterans Administration. So we learn from failure, not from success. And if you're really smart, you can learn from someone else's failure instead of having to fail yourselves. And that's the purpose of today's webinar. Einstein actually said, anyone who has never made a mistake has never tried anything new. And RPM and CCM are in many ways new. New regulations, new technologies, new procedures and processes. And so there's a lot of mistakes being made out there. And so we wanted to categorize them all for you as our top baker's dozen of mistakes for you to hopefully learn from. And it's important, we are required by law and custom to give you this disclaimer. The stories that you are about to hear, ladies and gentlemen, out there in webinar land, are actually true. Only the names and sometimes the locations have been changed to protect the innocent. And if you're too young to know what this dragnet thing is, please Google it, but wait until we're done with the presentation before you ask Mr. Google about it. Okay, so we're on to 13 major mistakes. Mistake number 1 is going too slow. Once upon a time, there was a community hospital in Indiana. And they decided that they wanted to have a remote patient monitoring program. And they said, let's start small and let's go easy. And so they really did start small and they really did go easy. It took them 2 years to grow to 20 patients. And what happened over those 2 years is that they never got any more patients because none of their providers even knew that this program existed. And there wasn't any impetus to it or any momentum. And then finally, someone said after 2 years, wait a second, we've been doing this for 2 years, and this administrative burden just isn't worth the squeeze. And so we're not getting any clinical effect from 20 patients. And so they canceled it. The takeaway is that any program needs to grow within reason until it means something to the provider. Now, what meaningful is depends on the provider, obviously, but it can't be too small so that no one knows that it's even there, or it will just die of its own inertia. And you can adjust growth from 1 patient a month to 1,000 patients a month Adjust it for what you need, but get to some level of gravitas so that people know that the program exists and that it's doing good work. That's lesson number one. Now, mistake number two is the other side of the coin. That's going too fast. Once upon a time, there was an FQHC, a federally qualified health center in Mississippi. Their CEO was very forward thinking, and she wanted the program to grow as fast as possible. She had 50,000 patients out there in the counties around her FQHC that had hypertension, and she wanted to take care of as many as she could as fast as she could. She ordered the vendor to grow to 2,500 patients as fast as possible, but no less than 500 per month. So the vendor went off and started doing that. Unfortunately, her staff was not on the same page with her, and they didn't agree with this rapid growth. Some of them didn't even agree with the program in the first place. And the staff wasn't ready when the patients actually began to arrive. Unhappiness ensued. That's the moral of this story. So the takeaway is ready, aim, fire is a cliche, but it's a cliche for a reason. You don't want to fire, and then aim, and then be ready. There is a certain amount of support required in any client, even if you're outsourcing these programs. And so you have to be ready to provide that support. And it's way better to find those problems when you have 20 patients than when you have 2,000. Mistake number three. This is one of my favorites. Letting the IT tail wag the dog. Once upon a time, there was a major hospital up in New York. And they really wanted to do in-home care because they knew it was good for their patients. They knew that telehealth into the home was the future of healthcare. And so they decided that they wanted to have an RPM program and then to get it started. But the IT bubbas came in and said, wait a second, we're a year away from a major EMR change, electronic medical record. And the IT guys said, we don't want any new projects. So now, 2 years later, the clinical teams and the population health teams are still waiting to deliver it because they got the Heisman from their IT gang. The takeaway is that if the client wants any one of these programs, RPM, CCM, TCM, PCM, RTM, etc., they can all be delivered completely independently and completely siloed from your EMR. Eventually, you're probably going to want to be integrated, but there's ways to do it so that the clinical people don't have to ask the IT people for permission to implement a new clinical program. And as I say, don't let the IT tyrants rule the clinical world. And I say that I have both IT tyrants and clinical people in my family, so I'm allowed to say that. Mistake number four, IT integration, doing too much too early. Once upon a time, there was a medium-sized hospital in the Midwest, and they were establishing an RPM program because they wanted to deliver in-home care for chronic conditions, and they also wanted CCM. But on the other hand, they were also integrating a new EMR. And for any of you who have gone through that process, you know what a process it can be. But the problem was they tried to automate the RPM process into the new EMR before the RPM process had kind of gotten squared away. It was still squishy and moving around because, as with any new process, it was changing. And yet at the same time, they were trying to jam it into the new EMR at the same time that they were trying to implement the new EMR. So needless to say, as they say in the fairy tales, unhappiness ensued. The takeaway is that new processes like RPM or CCM or any one of these other in-home programs, they evolve and they change with any client as they're implemented and pressure tested and as you work out all the kinks. There's a famous German general from the 1850s and the Prussian chief of staff who said, no plan survives contact with the enemy. I apologize, that's hopefully my only military reference in this talk. But what that means is you can have a really good plan, and still, once you start to actually implement it, it will change. So the takeaway is don't try to automate through IT until you've perfected it the longer and the more old-fashioned way. Okay, Mistake number 5, managing inventory in-house. Once upon a time, there was a doctor's office, a very busy doctor's office in a beautiful location in San Francisco. And they were implementing RPM, and they were very interested in maximizing their profit from the program. So they said, I know we can save money if we manage the inventory here in the office. So they bought a bunch of hardware in a bunch of boxes, and patients would come in and get a kit, and then they'd walk out. But the doctor's office would sometimes lose track of who had what kit. And if you're delivering data from a patient to a cloud-based software, you need to know, is that data coming from Mrs. Smith or from Mr. Johnson? It's pretty important to know who had what kit. And then when patients left the program, they'd walk back in with all of their pieces in a cardboard box, drop it on the desk, and then the desk would lose track. Who did this box come from? Was that Mrs. Smith or Mr. Johnson? Pretty soon, the doctor's office had a huge closet full of cardboard boxes and kits of dubious status and dubious origin. And, as they say in the trades, unhappiness ensued. The takeaway is, when in doubt, leave inventory management to people who do it for a living. Your average doctor's office or hospital is not accustomed to inventory management, which is shipping out to patients, which is being pressure tested by patient use, brought back to patients by patients, refurbed and reset and reissued. Let other people do that unless you think you're good at it. There are higher and better uses of the ample skills of the provider team. So our argument is stay at the top of your license. Okay, one more for me, and then we'll go over to Dr. Rowley, who's far more interesting. Mistake number 6, not worrying enough about revenue cycle management. These mistakes are not in order of priority, ladies and gentlemen, because if they were, this would be number 1 or number 2. Okay? Once upon a time, there were a dozen clients all over the nation, and they were sprinkled everywhere. For service. They all had an existing revenue cycle management capability, either in-house or with a vendor, because they lived off of reimbursements from CPT codes. And they all figured, hey, we're going to start RPM. It's just a few more CPT codes. What's the issue? How hard could that be? Well, we have found repeatedly that the new CPT codes are unexpectedly challenging for RCM teams and for the payers. Again, they're new. And as Einstein pointed out, mistakes happen when you do new things. And so unhappiness ensued, primarily of a financial nature. The takeaway here is do the financial legwork up front. We call it financial engineering. And then start with just a few patients and then seek reimbursement and make sure you get your money and resolve all those kinks before you start expanding the program. It might be a payer that's been paying you for the past 30 years when you do a strep test, but when you run an RPM code, they may look at you and go, what are you talking about? It might take some work with them to get it going. And I would say, thumper here, do not underestimate the initial difficulty in getting this started up. We found that people who do it at their own peril. Okay, now for mistake number 7, I'm going to turn it over to our able Chief Medical Officer, Dr. Mike Rowley.
Thanks, Rob. So I'm going to talk about the failure to show clinical efficacy. And my once upon a time story is a tale of two cities. For one group, that one client, it was the best of times, and for the other, it was the worst of times. So once upon a time, there were two provider organizations. In one, the chief medical officer felt really good about the program, but didn't have any empirical data to justify the clinical efficacy of the program. And the CFO had decided to kill the program. And by the time the CMO was able to collect all that information, it was too late. And in the other one, the chief medical officer had plenty of clinical efficacy throughout the life of the program. And I've been told that he was carried on the shoulders of his peers to a nearby bar. And I believe they're still celebrating. The takeaways from this is that, RPM and CCM and all of these remote programs are really all about the outcomes. She who has the positive outcomes, who has that data, will win the fight over whether or not this program is worthwhile or not. And I'd just like to share some of our experiences in terms of the clinical efficacy of these types of programs. So this first slide, we studied over 5,000 patients looking across multiple Blue Star clients. And we took a look at those that began the program with uncontrolled hypertension as defined by the CDC. That's a blood pressure greater than 140/90, and had participated for at least 4 weeks. And what we see is a very robust response that over the course of the first 2 months of being enrolled in RPM, we see an almost 10 millimeter drop in systolic blood pressure and a 6 millimeter drop in diastolic blood pressure. And these are very clinically significant reductions in blood pressure. Based on other studies, these types of reductions correlate to an almost 30% reduction in stroke and heart failure, and slightly smaller, but still very impressive, clinically significant drops in major CV disease events and all-cause mortality. Again, this is looking at a similar population. By definition, these were all folks that began the program with uncontrolled hypertension. And so you can see that in week 1, 0% of them were uncontrolled. And then over the course of about 2 months, almost 50% of them are in control. And that effect is sustained, at least as far out as we looked, which is 6 months. And then this last slide, I broke the population of uncontrolled hypertensives into 3 groups. And roughly speaking, they're uncontrolled in green, badly uncontrolled in blue, and really badly uncontrolled in red. And you can see that all 3 groups showed impressive improvements in their systolic blood pressure. And most importantly, the most significant gains were seen in the least controlled group. And in this group, the risk reduction for strokes was closer to 60%. And again, in all 3 groups, we see that these effects are sustained over the course of the program. So there's a lot of I'm convinced that this is a program that works, and it works well for patients. And if you're not getting data from whoever's managing your RPM program, you need to ask for it, because this is very important. This will demonstrate to other providers who may be skeptical that the program works. And it's very important when you're trying to justify this to your executive suite. I'll turn it back over to you, Rob.
Great. Thanks, Mike. We're about halfway through the webinar, folks. It's halftime. We plan on speaking for about 30 minutes, and then we'll take as many questions as we can fit in before the webinar's over. We will award 100 points to the person who has the best question, so please be thinking of them now. And during intermission, white wine is being served in the lobby. Okay. Mistake number 8, trying to do everything up front. Once upon a time, there was a very proactive physician in New York. And that practice wanted to do everything immediately. They wanted to do RPM and CCM, and they wanted to cover hypertension, diabetes, COPD, and CHF, all at the same time. Needless to say, as they say, unhappiness ensued. The takeaway is, when you're growing a garden, start with 3 easy plants. You're talking to a man who has killed many plants in his day accidentally. I recommend zucchini because I have found myself unable to not grow zucchini. But you can pick the others. When you're learning to play the guitar, just pick 3 chords. I found a book the other day of songs with only 3 chords each. So they do exist. And so when you're starting a program for in-home management of chronic conditions, CCM or RPM, pick 1 disease state and 1 population and 1 piece of gear and make that work, and then expand. Mistake number 9, lack of sufficient internal communications. Some of you have worked at big organizations and some of you have worked at small organizations, and it's astounding how much a lack of communications can screw up any program. Once upon a time, there was a big hospital in Illinois, and they implemented an RPM program. Unfortunately, the population health team implemented it, and not all the docs knew what was going on. Some of them did, but some of them didn't. And then the CMO and the CFO weren't on the same page. And patients were getting enrolled and their doctors didn't know that their own organization was doing it. In fact, we actually had a true story in which a patient asked her doctor about this hypertension thing, and the doctor said, "It's a scam for the elderly. Don't answer the phone and send back whatever they send you," even though it was the doctor's own organization that had solicited the patient and enrolled her. So consternation results from everybody, the people that are trying to do good and the other people that are trying to do good, and the left hand doesn't know what the right hand is doing. And as you know, the bigger the organization, the more left hands and right hands there are. So the takeaway is keep everybody informed and keep everybody understanding the rationale and communicate to them again. Then do it again and again and again and again and again and again until you're so sick of putting the word out that you think you're going to throw up if you hear it again. Because at that point, maybe 50% of the people who need to know will know about it. Use multiple means of communications. Use email and training and posters and bulletins, because no one modality of communication works. And then once the program's up and running, as Dr. Rowley pointed out before, pass around the good news. Hey, our patients love this. We're lowering blood pressure or A1C. This is why we have this program. Mistake number 10, failure to choose the right technology. Once upon a time, there was an FQHC down south, and they got a grant from our good friends at HRSA, and they bought a crap load of hardware. And the people that sold them the hardware said, "Here, you can hook it up to our free software." And so they did, because free software must be good. And the problem was the patients couldn't figure out how to use the hardware and the software. And the care coordinators on the clinical side were literally spending 90% of their time not doing clinical support, but doing tech support, trying to explain to little old ladies how to Bluetooth and things like that, how to download apps. The free software had huge ancillary costs, and so they killed the program. The takeaway is there's lots of tech out there. There are dozens of companies creating technology, both hardware and software, to support the remote patient monitoring and the chronic condition management and remote therapeutic management and all these other things. But it's not about the tech. It's how you implement that tech and how you choose it. And the way you choose it depends on your budget and your disease state and your population. There's no one size fits all. We deal with literally 85-year-old little old ladies in southern Mississippi and with 25-year-old young ladies who are pregnant in central Pennsylvania. We don't use the same tech for them both because there is no one size. Don't look for it. Okay, back to Dr. Rowley again, and he's going to talk about monitoring. Mike, over to you.
Thanks, Rob. Thanks. So this is a photo of a portion of Blue Star's monitoring team, and these are the folks that look at all of the readings that patients are taking on a daily basis. This lesson is underestimating the monitoring load. So once upon a time, there was a group of different providers kind of all scattered across the country, and they all set up RPM programs, and they all wanted to know every time there was an abnormal reading. And before they knew it, they were getting deluged with notifications that required their attention, or so they thought. In reality, not all of those readings required attention, and they then became unhappy with the program because they were persistently being bombarded with notifications that their patients had abnormal readings. The takeaway from this is that these programs exist for folks that have chronic conditions. These patients are not the picture of health. And so if you want to be notified every time their blood pressure exceeds normal by 1 millimeter of mercury, you are going to be getting a lot of alerts every single day. One of the reasons for outsourcing a program like this is to decrease your staff workload, not to increase it. There's insane amounts of information that are transmitted when you embark on a program like this. And part of the value of having a vendor is to create a clinical protocol whereby a team of monitors can look at those readings. They can call the patients, make sure that those readings are valid, that they've been taken correctly, that they've been taken under ideal circumstances, and then figure out and triage what to do with that information. If all of that information is just regurgitated back to the providers or to the clinic's care coordination staff, it's going to be overwhelming. And the point of this, one of the many points of an RPM program is to collect a lot of data, but you've got to understand you've got to create a workflow which doesn't make that amount of data create a overwhelming workload for your staff. Sort of going hand in hand with this is lesson number 12, and lesson number 12 is poor patient selection. And poor patient selection really comes in two varieties. The first one, and probably the most common one, is making sure that you have a patient population that will allow the program to be financially viable. We had a client that wanted to roll out the program to all their uninsured patients, and they didn't plan accordingly, and an insufficient number of their patients were able to achieve reimbursement, and very quickly the cost of the program became overwhelming for the health center, and it became unsustainable. One of the ways, there are a lot of clinics that do deal with very high levels of uninsured populations, but you can be creative in how you design your program so that you can create enough revenue from insured patients or patients that have adequate coverage to cover the costs for those that aren't. So make sure you really think through the finances. There was another client that rolled out the program, and they really wanted to use, they had all this great idea about the type of technology that they wanted to use, but unfortunately that patient population couldn't handle that technology. They weren't tech savvy enough, or not enough of those patients were tech savvy enough. And so they either didn't use the program, or they weren't using it appropriately or as frequently as they ought to have. And again, that caused the program to fail. And then the other thing is that, this program is not for everyone. There are some patients that are not going to be particularly interested in participating in a program like this, or very quickly after they enroll, they will want to disenroll because they are not interested. And so it's very important that you cast a broad enough net to compensate for the fact that not every patient is an appropriate patient for a remote patient monitoring program. I'll turn it back over to you, Rob.
Okay, thanks, Mike. We're almost at the end, gang. This is our baker's dozen. Mistake number 13, picking the wrong partner. Once upon a time, there was an FQHC out west. Now, for those of us on the East Coast, out west has different definitions. When I lived in the West, they never said out east. They used to say back east. And as near as I could tell, back east was anything on the other side of the Mississippi River. So this FQHC was on the western side of the Mississippi River, so we're going to use the appropriate moniker of out west. And they said, look, we want to expand our CCM program. We're doing some of it in-house. We're getting reimbursed. We have our own care team, but we want to do more, and we want to expand with an external vendor. So they signed a contract with a vendor, and they had a very defined scope of work, which was written in the contract. Unfortunately, that scope of work wasn't the same as what they had been doing in-house. Well, the vendor, in a foolish way, did what was in the contract, and then the FQHC realized after a number of months that that's not what they really wanted, because that's not what they were doing. And so needless to say, legal unhappiness ensued. The takeaway is picking partners in marriage and tennis and RPM and pickleball and bridge can be hard. But the more work you do up front, the less heartaches you'll have later. And the scope of work is extremely important. There's lots of things to do. We have identified 30 or 35 tasks that have to be done every day in an RPM program. Which one are being done by the client? Which one are being done by the vendor? You got to make sure everybody knows who's doing what, and that that's written down to avoid uncomfortable ambiguity later on. Okay, ladies and gentlemen, because you've been so nice, and you all came back from intermission, we're going to give you an extra free bonus mistake, and that's mistake number 14. And this mistake is occurring at thousands and thousands of physicians' offices and FQHCs and hospitals and payers across the country. And that mistake is not doing anything. Once upon a time, there were thousands and thousands of medical care providers all across the country, and they all had older patients. They all had older patients who had chronic conditions that, in theory, could benefit from management in the home, and in theory, could be done on a cash flow positive basis. But all of them were as busy as hell, okay? And they all had huge to-do lists, and they all were overwhelmed, as it were. As my daughter, the nurse at a local hospital, tells me almost every day, hey, every healthcare organization in America is overworked and understaffed and underpaid and overwhelmed. And the last thing we need is some new damn program thrown on us. Too many of them assumed that RPM was just too big to tackle right now for any one of a number of different reasons. So for all those folks, nothing happened. And it might have been okay for the staffs, but it wasn't as good as it could be for the patients. The takeaway is there are at least 25 companies in America that can help you implement RPM or CCM or RTM or PCM or any of the other M's at your place, and they can help you do it profitably. You can outsource most of the work to them, and you can just keep in-house the things you actually want to do. So we recommend that you take the plunge, try something small and discreet, make it work, and then grow it. Your patients and your organization will thank you for it. Okay, and this is Blue Star here in Times Square on Veterans Day, and we are going to turn it back over to Rebecca, and we'll answer as many questions as we can. We will give you relatively short answers so that we can get through as many questions as we can, and if we don't answer it completely, send us an email, and we'll be happy to follow up. Okay, thank you, Rebecca. Back to you.
All right, now as you said, we can move on to the Q&A. You can still submit questions using the Q&A tab to the left of your screen. I see we have a lot of questions already. We will do our best to get to as many of them as possible. All right, let's begin. First question, our patient population is very rural. Is RPM still a viable option?
We get this question all the time, and we do Wyoming rural, okay? We do Saskatchewan rural. Um, any place in America is generally findable, and people overestimate the inability to reach rural audiences. Remember, we're not streaming live video, we're sending little bits of data. And so we have 1 out of 1,000 patients is unconnectable, if that makes sense. And it might even be lower than that. So the answer is yes, we can satisfy every rural need.
Great. For the next question, what disease states do you find most clients are using RPM for?
Mike, you want to take that?
Sure. It's, I would say by far the most common indication that we have seen that people ask for programs for is hypertension. And that's probably just a result of the ubiquity of hypertension in the general population. That being said, we probably the number 2 indication would be diabetes, followed by CHF, COPD, and then it is probably evenly distributed among all sorts of other chronic conditions.
All right, thank you so much. And the next question, how good is the patient retention in these programs?
When I was an admiral and someone would ask me a question, or I would ask a question and they would say, it depends, it would always irritate me. But the answer is it depends. We find that the first thing to do is only have volunteers. Don't assign people to this program. So we explain the program to a patient, and then if she decides to be in it, she's a volunteer. She's interested in managing her health. That said, we still see 3 to 4% monthly attrition. So even if people are very interested at the beginning, after a while, some of them lose the interest. And then when they're not compliant anymore and they're not really playing in the program, then we'll request the client's permission to disenroll them, and we'll disenroll them. So retention is an issue, but typically that means that when Mrs. Smith leaves because it's no longer helping her, we bring in Mr. Jones as a new patient to take her spot.
All right. The next question, how do you integrate with EMRs?
Mike, I'll take this one too. EMR integration is important, but it's overblown. We typically start programs completely independent from the EMR. Here's the system that we're using, and here's the EMR. And if the system that we're using has to talk to the EMR, we do what we call manual integration. We literally just enter the information into the EMR. Because if you start with an EMR integration, it can be a 6 to 12 month delay. And we'd rather integrate after we get going. Once it's up and running and successful, then we'll do the integration. And it's simply a matter of getting the IT gangs on both sides to establish the APIs to have whatever software system we're using talk to your EMR.
All right. How long does it take for a typical client to get the program going?
Mike, you want to take that?
Sure. And unfortunately, this is another it depends question. We've been able to get programs up in 30 days, 30, 45 days from the time that we've started working with a client, and we've had other clients that have taken 6 months or longer. There are a lot of components. As you can see, we went through 13 plus lessons learned, but that being said, there really is no inherent obstacle to getting a program up and running from the time you make the decision to implement the program that you couldn't do it within 6 to 8 weeks, if not sooner. Yeah, I mean, I think that's.
Yeah, we have a very organized onboarding program, and it really depends on the client. But it could be 30 days if you're interested.
I mean, there's essentially, there are a few things. It's essentially a checklist of things that need to be accomplished, and as quickly as you can get that information, we can get a client on board.
All right. This next question has two parts. I'll need you to listen up a little bit. Two questions. How do you balance the desire of the RPM vendor to maintain members on RPM and the fiscal need for payers to utilize RPM only as a relatively short-term adjunct? And how do you ensure patients on RPM don't get technology dependent, but instead utilize it as an opportunity for patients to learn to better self-manage?
Okay, both good questions. So let me do the first one first. It is easier if an RPM patient just stays on for 3 years because it's less work for the vendor and it's also less work for the client. But we understand that it might be better for the client to bring Mrs. Smith into the program for 6 months and then graduate her into not being on the program, which gets to the part of question 2. These are good questions. And with the Veterans Administration, for instance, they have nearly 100,000 veterans in their RPM program, and they firmly believe get them in, get them through the program, and then get them out. They want a level of churn because they don't want this to be a lifelong program. So there is a balance, but in our view, let's pretend that Hospital X says we're going to have 1,000 people in the program, and every month 50 of them are going to leave, but we're going to add 50 new. From our perspective, that's fine. We just have to set up processes to make that happen. And so I don't think that there should be a tension between a vendor desire to have long-term patients and the clinical desire to move patients through the program. The second part of the question is about people becoming technology independent. Ideally, we sign up Mrs. Smith and she has a cellular blood pressure cuff and the data is going through the cloud and people are looking at it and she's interfacing with the team. But ideally, 6 months later, she manages her own hypertension with a CVS or a Walgreens blood pressure cuff by taking readings regularly, by eating correctly, taking their medicine, lower salt, all those kind of things. So in a perfect world, you take people through the program, you teach them to manage their own condition, and then you move on. So those are very good questions, and those are subtle things that are very important in a population health environment. And we'll move on to the next, only because interest of time.
All right, well, the next question is a lot more direct. How often is a patient's blood pressure taken?
Doctor?
So that's a good question. And it's, clinically, it obviously depends on the patient. We for reimbursement purposes, one of the CPT codes for RPM requires that a patient takes 16 readings over the course of a 30-day period. It's hard to tell someone to take 16 readings in a 30-day period. So usually we recommend that patients are instructed to take their blood pressure at least once a day. We work with each of our clients to determine what their providers want. If they want us to say twice a day, then we'll say twice a day. If they want us to do one before they take their medications and one afterwards, then we will advocate for that frequency. But really, the most successful programs that we have are the ones where we tell them to take whatever reading at least once a day. And then if they haven't taken a reading in 2 days or longer, then we'll call them up to remind them that they should be taking it at least once a day. Great question.
That leads into the next question there, Rebecca.
Yeah, it does. The next question, how do you motivate and incentivize members to hit that 16 times per month in the Medicare line of business for full reimbursement?
So for those of you that aren't familiar with this, in order to be reimbursed for 99454, which is one of the RPM codes, you have to have readings on 16 days of the month. And so if a patient only takes 15 readings, then it's not reimbursable. So the question is, how do you get those 16 readings? Well, one, you get them by establishing a relationship between the care coordinator and the patient. Two, there are technologies that can reach out and ping on the patient when they're not taking their readings. Three, we are experimenting with incentive programs. For instance, we have a pilot going on out in Indiana where we have a couple of hundred patients, and we're saying, hey, of all the people that get 16 readings this month, you're going to be entered into a raffle, and one of you will get $250. And so we're trying to figure out how much of an incentive that is. And so it's an excellent question. This is a smart bunch you have here, Rebecca, and it does get at the heart of it. Typically, we program for 70 or 75% compliance with the 99454 16 reading rule. That's what we have seen out in the industry.
All right, moving on. Can an FQHC bill for remote patient monitoring?
For many years, they could not. FQHCs, if you look back at the Einstein slide and you try to study his theory of relativity, and then you try to study reimbursement for FQHCs, you'll find that relativity is easy compared to understanding reimbursement for FQHCs. But for a long time, they couldn't get reimbursement for RPM. For many of our FQHC clients, we're actually doing RPM, but we're billing for CCM. Now, as of January 1st of this year, FQHCs can be reimbursed for remote patient monitoring using a G0511 code. And going into the details of how that works is beyond the scope of this conversation. You can email us and we can fill you in on the data. But the answer is now, yes.
Great. What do you mean by cash flow positive?
Cash flow positive means that the client is reimbursed more for the accomplishment of the CPT code than Blue Star is paid or a vendor is paid. So if you perform a CPT code and the client receives $50, and if you pay the vendor $30, then that's $20 of cash flow positive for the client. And as Dr. Rowley pointed out earlier, these programs, if they're not financially viable, they go away. And so one of the ways to make them financially viable is to make sure that the expenses are lower than the reimbursements.
All right. How does an outsourced care management team know what to do with patients?
That's a protocol question, Dr. Rowley.
Yeah. So it's what we call a clinical protocol. So one of the first steps that we do once a health center decides that they want to implement an RPM program is I have a conversation with whoever their clinical leadership is to determine how would you like us to handle those values? How would you like us to respond to those patients? When do you want to know about Mrs. Smith's blood pressure? When do you want us to just tell her to check it again and continue to monitor it? What is the sort of information you'd like us to provide to the patients when over time, over the course of the protocol? And all of that is it's a brief, relatively painless process. We have best practices that we use as a template, and then we send that to the client, and they can review that and say, well, we'd like to make these adjustments in terms of the thresholds, or we'd like to, instead of being notified through the EMR, we'd like to do that in a once daily email or by phone or however they want. And all of that stuff is outlined before we ever start with the first patient. And again, for any new client, this is going to be a new process. And so it's not uncommon that we revisit that clinical protocol regularly to adapt it to better fit with either the health center's workflows or depending on the results that we're seeing in terms of patient compliance or results in the program.
Moving on, how do you handle patient copays?
As you know, patient copays are required to be attempted to be collected. So we have some clients that are very serious about that and they work copays hard. We have some clients that don't even try to collect copays. And we have some clients that try to collect copays, but not very hard. In other words, they'll send out a bill, but they never expect anybody to do anything about it, and so they don't collect it. There is a copay for these services, depending on what services are being provided, either CCM or RPM, and depending on 100 other variables, it can range from $5 to $15 a month. When we enroll patients, we inform them of the potential copay. And so, in a short answer, that's how we handle copays.
My apologies, just doing a little administrative stuff here. The next question. The 2024 physician fee schedule also added general care management code G0511 for rural health clinic or federally qualified health center, only to bill for RPM or RTM, but not both.
And then that was kind of a statement. And then the same questioner said, followed with a question, what do you see as the challenges to service rural patients with RPM? Poor selection of patients, could be less doctor visits, et cetera, et cetera. It's a very good question, questioner. And again, technologically, there's no real worry about handling rural patients. If they have cellular connectivity or Wi-Fi or cable, and frankly, even if they just have a regular phone, we can connect with rural populations. How that affects the client's ability to manage those people is different. Our view is that you shouldn't have less visits to that patient's house because they're on RPM, but you could do the same number of doctor's visits and you could be to homes and you could be visiting the people that most need it. That's what RPM is about. It's being the canary in the coal mine. And so if I have 1,000 people out there with hypertension and I can only deliver 20 doctor's visits a week, let's go visit the people that need it the most. So we think that the two of them are not opposed, that they can be complementary, and that an RPM program can assist in rural health initiatives, not oppose them.
And if I'm understanding the question about not doing RPM and RTM simultaneously. It is true that they cannot both be billed simultaneously. However, if you had a patient, if you decided you had a program where you wanted to look at hypertension and diabetes, you can't bill for those separately. But obviously now you're using two different devices, a glucometer and a blood pressure cuff for those patients. And so a similar design could be implemented if you were going to do RPM and RTM. Only one of those would be counting towards the codes, and the margin for the cash flow positivity would be less because there are additional devices, but it doesn't exclude the possibility of doing both. It's just you won't be, it'll be at a lower margin level than if you were doing one.
All right. For the next question, how do you believe CMS may change rates and requirements as CCM and RPM codes get further uptake? Some venture-backed companies that operate full-stack monitoring service, own MDs and nurses, and that didn't exist 5 years ago, they now generate over 50 million in revenues. Will CMS crack down and make it tougher to operate RPM and CCM operations, perhaps with more stringent requirements and quality reporting?
It's a very good and a smart question, and my ability to predict the future is no greater than any of you out there in webinar land. In recent years, the reimbursement rates for RPM have been decreasing, while the reimbursement rates for CCM have been increasing. So is that a signal from the feds that they want us to do more CCM and less RPM? I don't know. We definitely think that there will be a shakeout, and that companies that exist to provide RPM when it's not needed, or clinicians that provide RPM when it's not needed, we think that they will get found out. We have run into some clients where we can tell right off the bat that all they want to do is sign up a zillion old people in their office and give them gear and bill against it. And we don't take those clients because that's not what the program is for. We have seen, as Dr. Rowley pointed out, the fact that we can actually reduce the risk of stroke and heart attack in little old ladies in southern Mississippi by between 30 and 60%. And that data is good data, which we have sent to HRSA. And so RPM will continue to exist for things like that. Will there be a shakeout? Maybe. Companies that are only doing RPM in a full stack, they will be the ones where RPM is one piece or CCM is one piece of a well-balanced, care package for your patients. We think that it will still be available to you. And that's my prognostication of a future that none of us will know.
Okay. Who is your biggest advocate in a facility or a physician office?
That's a great question. We hope it's everyone, but in reality, I think there's two. They come in two flavors. One is a clinical, is a provider usually that really wants to do this for outcome data, or because they're techno optimists and they want to do whatever they can, and they've heard about RPM and they want to be able to offer it to their patients. That's probably number one, and oftentimes those are the most successful advocates to have, because they have the clinical gravitas, they have the weight of being a provider to make the strongest case. The second most common would be somebody who works in like a QA department, some sort of quality assurance person who is just tracking metrics and wants to get those metrics higher. They can be great advocates as well, although usually kind of in the health center food chain. There's a middle person who is a higher level clinical decision or a decision maker above them who is pulling the strings, and it's worked out great with a bunch of different clients. Those are the two big ones. Occasionally we'll see a CEO who wants to do this. We've had some financial folks, but that's more the exception to the rule.
This morning we
Yeah.
had Dr. Rowley and I spent an hour with a huge practice in Florida, and it was the clinical director and the head of quality were the two people that
Yeah,
wanted to
that was
talk to
a
us.
great combination to have on a call who were interested in RPM because they're going to make sure it works.
Okay. What percentage of patients typically will do the program if it's offered?
We have pretty good data on that. Classically, let's say they run an EMR query and say, we have 1,000 folks who are hypertensive and who are uncontrolled and who are reimbursable. And we just pick hypertension because, again, it's easier for me to use as an example because it runs in my family. They'll give us that list of 1,000 people. And then Blue Star will go out to those folks and call them on the phone on behalf of the client and explain the program and explain how it works and say they've been recommended by their provider and do you want to try it? And we get take rates between 25 and 50%. And it depends primarily on the extent of the copay. So, as a rule of thumb, if you offer it to 4 people, 1 will take it. If there's copay help, 2 out of the 4 will take it. We're not hearing you, Rebecca.
I think you're on mute, Rebecca.
My apologies. Sorry about that. As I was saying, we're coming close to the end of our hour here. We will do one more question. And as a reminder to the audience, you can download today's presentation by going to the Handouts tab over the Q&A tab on the left-hand side of your screen. So go ahead and grab those if you want to take another look. For our final question, how does this apply in a value-based environment compared to fee-for-service?
That's a very good question and a complicated one for those of you that understand the nuances between fee for service and the value based world. The in the fee for service world, it's very simple. Who's paying for the program? It's some payer somewhere, Medicare, sometimes Medicaid, or a private insurance company. In the value based world, payers are paying for services like this to improve outcomes and to eventually lower their costs. So when we work for a payer, we're not submitting CPT code claims. We're just simply saying we provided maternal health to this many young ladies in central Pennsylvania this month. Here's our bill. And then it's up to the payer to decide, okay, we as a payer are getting more value in cost avoidance of preterm pregnancies and preterm births and early hospitalizations and things like that. We're saving more than we're paying Blue Star. That's a complicated equation. It's done on a payer by payer basis. The clinical benefits of RPM clearly translate into the payer space. It's just that the financial implications and return on investment have to be decided on a case by case basis by each payer. It's complicated. Good question.
All right. Well, thank you so much. Thank you to everyone who attended today's Fierce Healthcare webinar, and thank you for submitting so many great questions. I'd like to thank our speakers once again for participating and Blue Star TeleHealth for presenting today's webinar. A recorded version of this webinar will be available for you to access within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.